I really appreciate you all coming down to be here. But I think I know why you're here, because you know just how important this is. As Doug mentioned, he and I are part of a what's called the Low Carb Action Network, LCAN, which is an advocacy arm to make sure that low carb gets included and properly evaluated in terms of the guidelines. So we have two challenges in terms of getting the advisory committee to acknowledge low carb and then properly define it. Right now, their proposal is to consider anything that is 45% of 45% carbohydrates, low carb, which is absurd. But we'll get that fixed. But that's also part of the challenges, and most people don't know or understand actually how we even create these regulations and laws and standards. But so this is why it's important for you to at least some level and challenge yourself, raise your level, what I call literacy on this, so that you understand, so that you can make and provide really informed, educated input into the process. So what we're going to cover over the next 35 minutes is a contextual presentation about how do we transform what we learn, what we know, what our experience is, what from both the clinician and the patient into healthcare policy. As we know, everybody knows, the cost of healthcare is ridiculously high. The cost of diabetes care is ridiculously high. Obesity is devastating everyone across the board. And as we saw in the presentation yesterday, no country has reversed the obesity crisis. And it's kind of ironic. We're worried, there are people right now on the planet worried about how the planet's going to be fed 50 years from now, promoting a primarily vegan type diet. And meanwhile, we have a global population that's suffering from energy, what some doctors would call, have defined obesity as energy toxicity. And so too much. And so we really need to approach this for the sake of our own health, both physical and mental. So we'll tell you a little bit about, but before I even continue, I want to take a minute to thank and acknowledge Doug Reynolds and Pam Devine, his partner. These conferences are critically important. They bring the community together, they bring out the science and clinical findings and discoveries, and they empower us and they educate us as patients. So imagine if we had these conferences in our respective states and communities. And imagine if all medical health professionals were trained in metabolic health, regardless of whatever their discipline is as a health professional, but at least had some training and understanding or literacy on metabolics. And so what Doug and Pam are doing, besides, this is not just a business, this is a labor of love for them. And I am deeply grateful that I've been part of this community since the get-go, since he first started this. So thank you, Doug and Pam, always for the great work that you do. And they really work hard to put these conferences together. A little bit about me. I'm 56 years old. As an attorney, now practicing attorney now 24 years, government relations professional. Ever since I was a teenager. I had the privilege to serve as a U.S. Senate page for Senator Jacob Javits of New York, and learned how government worked very early on. Today, I'm now a candidate for the New York State Senate in the 38th District, which is Rockland and Westchester, New York. And we're just getting that started. And I had type 2 diabetes diagnosed in 2002, a family history of diabetes, mom, dad, grandpa, aunt, across the board. Typical Hispanic American profile with a genetic predisposition to both obesity and type 2 diabetes. I was put on metformin on diagnosis, and then in 2008, I graduated to Janomet, and then on March 29th, 2014, I had a heart attack, a stent placement in the circumflex artery on March 31st, 2014, and then I was put on 3 additional prescriptions on discharge. I began a low-carb keto diet against the wishes of my primary care physician, who was kind of like, oh, well, sounds kind of dangerous. But meanwhile, he was happily surprised when we did the first set of labs in September 2014. I had a normal A1C for the first time in like 12 years. And he said, whatever you're doing, keep doing it. And I started coming off all the medications. And then I did something else. I started tracking, and I really suggest everyone here who is a patient, and even if you're a doctor, start tracking. How much does this stuff cost? Because if you want to change the law and change the policy, we need data. So it's, in my case, to date, I aggregated because if I was still not doing this approach of keto carnivore type diet, I would be on diabetes medications, and that cost to date would be in excess of $24,000 in my case alone. And try to imagine that, like in the state of New York, 12.5% of the population, greater than 12% of the population in my state, have diabetes. And this really impacts things that are really local levels. So you have to really think long and hard. But the most important thing that you can do is to start to keep statistics about yourself. How much are you spending to take care of yourself? And how much are you spending on prescription drugs? And how much have you saved since coming off of them? Because folks like myself who aspire and will be serving you in the legislature, we need this information. Because when we have the policymakers and everybody in the room, and we have to make hard decisions, we need to be able to say, look, we've got to make some adjustments here. Why aren't the doctors? Everybody recalled during this conference, I kept asking in almost every presentation if what was presented was taught in medical school, and the answer is no. Why? We need to change that, and we're going to talk about that. So, off all of my prescription drugs, I will say that my cardiologist would like me or has me taking Vascepa, but I've always taken fish oil and omega-3. I think that's a very important and underappreciated biomarker that we should all be taking into account. So what were my benefits? I returned to college weight, clothing size, other disclosures. I'm a board member of the National Alliance for Better Nutrition and arm of the Nutrition Coalition. I represent clients in this community on these issues. I represented a parent of a type 1 diabetic child who was being challenged because her custody was being questioned, or her care was being questioned, because all she wanted her child to have was not be on a roller coaster of high blood sugars. And but we were able to successfully resolve that case and settle that case. And we also need to address that problem that type 1s have, and the parents of type 1s that struggle with this on a daily basis, on how to keep their kids from being on the high blood glucose roller coaster that comes with the condition. So this is an inspiration for policy, legislative, legal development in New York, and it's my commitment that I'll get this done when I get to Albany. So how did we get here? Well, most people don't use root cause thinking, and that's unfortunate. We need to start adopting that, which is like, well, why? What caused this? And making the adjustments there, not being in reaction to the problem, but actually getting down to the heart of the problem and making the fixes there. And it's unfortunate that most medical doctors don't know or fully understand the metabolics of health and its relationship to nutrition. That's clear to me. Why? And why aren't they're not taught primary prevention? They're not trained to think like engineers. And in medical school, they're not taught therapeutic and metabolic nutrition. And also, in the business sense, from the business angle, they're not financially or professionally rewarded for preventing disease. So like in my case, if I've saved $24,000 in not using prescription drugs, why aren't the doctors who know about this and help me with this aren't getting acknowledgement or getting some financial reward? Meanwhile, if I hadn't done this and I was still on the prescription drugs, the shareholders of the drug companies would be ones getting the benefit. I kind of kid around. I said that in September 2014, I stopped contributing to the 20-something million salary of the CEO of Merck because I stopped using Janomet because I don't need it. And many type 2 diabetics don't need all of this medication if they were given the knowledge and the doctors knew about this option. And the only way this is going to change is by taking action at the local and state level. This is not something that's going to be handled at the federal level, unfortunately. But, you know, all politics is local, as they say. So, and here's the other problem contextually. Our system, and I'm not trying to pass moral judgment on it, but there's something wrong where you profit more by treating disease instead of curing or preventing it. And processed food companies make more money than other food companies. We're seeing the decimation of real food. We see small family farms being closed down. We see the problems with or the attacks on meat, and there's all kinds of food safety issues that are constantly present. So we're really in a challenging moment because, as we know, people who follow this lifestyle and diet, we don't eat processed foods, very little processed foods. Our food is fresh, doesn't come in a box, doesn't come in a plastic bag, and we need to be thinking about how we can promote real food. And it's like Dr. Iflin talked about yesterday in her presentation, the processed food is devastating our population, our communities, with the consequences of the food addiction that we see in all ways. And our country is in trouble. We are in a very, very challenging moment in our time in history. And we need to be taking care of our health, and in that vein, taking care of each other. So how can keto, low carb compete in such an environment? That's a very good question, but we tackle it. Most people don't realize, and as was also pointed out, like Dr. Tro pointed out yesterday in his presentation, pharma and processed food companies contribute to medical education. Everybody know about Nestle's? Nestle has the Nestle Nutrition Institute. They influence medical textbooks and levels of medical school education across the country and around the planet. So it's all about the money, for better and for worse. So what can we do civically? And this is what I call, at least, and in my platform in New York, I have a platform called Civic Literacy, or Literacy. And get involved, we've got to start imparting certain principles. One, if it does not get measured, you do not know, and it will not get fixed. This is why the first way, and we all know this from when we started the keto diet and using macros and things, we started measuring and looking at what we were eating and how much of it and when, and started calculating all of that. And it's that rigorous discipline that needs to be applied. Same thing. How much are we spending on prescription drugs for this condition? How often do we go to the doctor? What does this cost us? And what is it costing me? And what is it costing my family in terms of time and money? And remember, time that you spend is time you will not get back. Time is your most precious resource right next to your health. So look at that and document it. Write this stuff down, because anytime you go to a town hall meeting or talk with an elected official, have your data. We want to know. It's like very important for me to know how many people in my district are dealing with these diseases, these conditions, how it affects their lives, and what it's costing us. And to put it in stark terms, in New York, we have right now a $6 billion deficit that has to be made up in the area on Medicaid, which is health insurance for the most neediest segment of our community. And New York State does not have the US Treasury to print dollars, so we have to make up that shortfall. And it becomes a very difficult and painful exercise because the legislator has one of two choices. Either they're going to have to raise revenue by increasing taxes, or they're going to have to reduce services or cut services to people. And so I know, for example, with diabetes, which costs just in Medicaid alone $1.5 billion in New York, that can be reduced if the doctors knew and the patients knew about, who are type 2 diabetics, about low carb, and giving that as an option for them to try. And I'm also going to talk about how to engage other segments of the community to support that. So look at that. See, we have over 2 million persons in New York alone with type 2 with diabetes, and over 12.5% of the population. So you should be finding out how much, whatever condition you are dealing with, using keto, low carb to improve or reduce or eliminate prescription drugs. Find out what's going on in your communities and let your elected officials know, because we struggle with this. Because when they have to make the decisions, budgetary decisions, it's hard. And how do you say to someone who needs certain services because it's a matter of life and death that they're not going to be there? It's really tough. So the other things I want to encourage is, wherever you live, form meetup groups. We started a New York Diabetes Remission low carb group with Dr. Tro, and Dr. Tro is doing some wonderful things he had in his clinic with support groups for people with diabetes and are dealing with obesity. So one of the things that we looked into is, what is a typical medical school curriculum? Does everybody here know what they actually teach in medical school besides the doctors? Okay, well, here's Cornell Medical School. And I didn't go to Cornell Medical School. I went to Cornell undergrad in Ithaca, but I wanted to use them since I'm connected. And so here's their curriculum as they publish it and present it to prospective medical students. And so what do you notice and what's missing? So they have what they call 3 phases: foundations, we go essential principles of medicine, health, illness, and disease, parts 1 and 2. And then they transition into clerkships into those different specialties. And I would assert that in each one of these areas, there is space where there should be teaching metabolic, nutrition, food, all these different aspects, and they're not doing it. And they actually inculcate a mindset which is classic pharmaceutical thinking. I'm going to show you an example of like what the guidelines for diabetes. These are all of the medical school education. So what should we be adding to this curriculum? So when I was looking at this, I said, gee, there would be 4 things that I would be adding. I would want my doctor to know. I would want my doctor to know therapeutic nutrition. I would like my doctor to be think more like an engineer, and with their understanding of metabolics. I'd like them to understand food addiction, because the food addiction is tied right into chronic disease. There's almost always a connection between chronic illness and food. And then it'd be nice, the doctors to actually learn to cook and actually know how to prepare meals, because the doctor that actually can do that and say, have in their office a kitchen and bring their patients. We need the people, we are disconnected from that aspect in our lives. One of the things that I'm promoting in my platform as a candidate, I want to bring back home economics and cooking and shop class and these kinds of things that we've taken out of the high school curriculum. So these are the things that I want to bring back. So look at this medical textbook, Guidelines for Diabetes. And full disclosure, I thank Dr. Ken Berry for this, because he he tweeted out this photo, and I'm sorry I can't zoom in, but it just basically, it says a patient with type 2 diabetes and an A1C equal to or greater than 7%. What's the procedure? How would you, in this flow chart? And it says metformin, titrate to maximum tolerated dose. And the goal is usually less than 7%, but should be individualized. I would just simply say, when I had my heart attack, my A1C at admission in the ER was 7. So I still don't understand, or what's the logic why we would tolerate such high blood sugars in type 2 diabetics. It's like we're walking time bombs in terms of a cardiac event with elevated glucose that high. It's just ridiculous. And I think of Dr. Bernstein, who says every type 2 diabetic is entitled to have normal blood sugars. And it is possible, and you can do it. And it's like the people that we know, I've been doing keto, now carnivore, for 5.5 years, and I've had a normal A1C throughout. So it is possible. And then you look at this flow chart, and there's no mention about diet in any of these interventions along the way. And then if there isn't improvement, they want to put the patient on insulin, and a type 2 on insulin, when type 2 diabetes is a disease of insulin resistance to the max. It's really tragic. So what I hope to do, what I will do if I get to serve, is I will bring up these clinical guidelines and start asking questions, because the other part of this is you have to take it upon yourself to understand how the medical school and education curriculum is developed in your state. The practice of medicine is regulated by the individual states, not the federal government. So this is something that must be done on the local and state level. The other thing I want to do is bring doctors and farmers together. We don't have that. That's a missing component. And that's another reason why it would be a great thing to do, and I want to explore how we can do that in the state of New York. Something else that I'm also promoting is a reform in the supermarket. We have farmers markets on the weekends in the state of New York, but I want to bring the farmers market to the supermarket every day. I would like every supermarket to have a certain percentage of its space devoted to locally sourced, state-produced agricultural and produce, meat products and all that, so that the consumers can patronize and support their local economy and the local family farmers, not the giant industrial farms. So it would be really important to have the doctors have interactions with the farmers. And the other thing, obviously, is I want to encourage people to buy more direct. And how many people have visited or taken their kids to visit farms and ranchers to go shopping? Anyone? Yeah. We want to keep promoting that. So how are we going to do it in New York? Well, there are two entities in the state of New York that really have oversight over this, besides the regulatory agency that deals with the practice of medicine, which is the Office of Professional Medical Conduct. But in terms of education, you have the New York State Department of Education and the New York State Board of Regents. And so what I will do is start a process to modify requirements to obtain a Doctor of Medicine, an MD degree, and the license to practice medicine to implement mandatory education, both for new doctors and then for doctors with licenses to have the CME. And the challenge will be is to actually come up with those modules and that training of what should be taught, what should be covered. But we need to start that conversation. And it isn't something that's going to happen necessarily in 1 year. It would be a gradual process. But we need to come to that point where we can start this process. And I would like to see CMEs in nutrition and metabolic engineering of human health and disease prevention. Those should be modules added to the CME. And also, I want to financially reward doctors who get their patients off prescription drugs by sharing or rebating some of the cost savings through a transparent, accountable mechanism. I've heard from some people that this can be abused, and yes, anything can be abused. So when you have a program like that. So there always has to be accountability and transparency. And that can be done by having it properly regulated. But why shouldn't a doctor who does a good job and actually keeps his patient healthy and reduces or eliminates the need for prescription drug medication, we need to be promoting and encouraging that. So that can be done through a system of working with insurance companies and perhaps creating a board or an entity to set up the standards and the criteria that will allow that, and also make it very clear. Dr. So-and-so gets an additional, has earned X amount of money because he's helped his patients stay healthy. I want to be going to doctors that actually get their patients healthy and get them off of medication. That's a good sign, to get results. That's who we want to be promoting that. So again, as I mentioned, we also want to promote real foods, local agriculture, what I call my local agricultural supermarket initiative, farmers markets in the supermarket every single day. And then the other things that I want to look into and we need to think about is eliminating or reducing taxation on equipment related to anything that promotes health. We should be promoting everything, getting people to the gym. We shouldn't be taxing, if sleep is so important, we shouldn't be taxing mattresses. There should be no sales tax on mattresses. That may save you a couple of between $50 to $100 depending on the type of mattress you buy. But that may make the difference of buying a better quality mattress. So that's we want to look at things like that. Anywhere we can promote health, you need to be looking at with eagle eyes, are we stifling, are we making it more difficult or more costly to access something that will promote our health? The other thing I want to do is, and this is all in the context because we have this national debate about free college and free tuition and all of that. I'm not all the way there on that. I think we need to look at, in our individual states, what are the professions and occupations that will help our communities, and then we can say to our young people, hey, this county, this part of the state needs a doctor. We will put you through medical school. You just give a commitment to serve that community for 6 to 10 years to give back to it. But we will, the people, our tax dollars will support you. So we need to tie education to have it being purposeful. If we're going to be funding it, everybody should get a great education, but it needs to be connected. And so I want to look at that in the state of New York. And there's a diabetes prevention program in New York, and I intend to hold them accountable as a legislator. It's like anywhere where you see where there's a quote-unquote diabetes prevention program, you need to start asking them hard questions. How much are they spending? And for goodness sakes, what are the results? How many people have been brought into remission or have reduced the need for medication or have come off medication? Real markers, not this talk, oh, well, we had all these classes and we're preventing. You have to think about this in terms of having an accountable conversation with any of these people involved in these programs. So if I'm elected to serve, I will hold public hearings and I will keep pressure to bear for change at every level. It's important that the public, and when there are hearings, when you hear about it, ask your elected officials, when are there hearings on this subject, and tell them you want to go and testify. As a member of the public and as a voter, as a constituent, you have a right to speak publicly and provide input. We need that. It is so important. Everyone here is a citizen registered to vote? And everybody's going to vote in November? Great, because everybody's got to be involved. You got to have, as I said, skin in the game if you want to win in anything that matters to you. And so what I would like to do about this issue about Medicaid and diabetes and at $1.5 billion in New York, I'd like to start some pilot projects where we can start testing this and start really doing similarly like what Virta Health is doing, which Virta Health is a company that gets type 2 diabetics off medication, reduces medication, gets them into remission, and they don't get paid if they don't get results. So that is a game changer. And then Dr. Stephen Tucker yesterday talked about CGMs, and I as an elected official will want to make sure to make it easy to get as many people to have access to a CGM, because that is the most telling thing that a person can see in terms of how food impacts their metabolism. And we can prevent more type 2 diabetes if we started using, that people had access to CGMs, but we got to get the cost down. We have to make it affordable. It's still not affordable. So, and economically, and the bottom line, it's about making healthcare and prevention more profitable than sickness at every level. That has to change. And that is the conundrum, that's kind of the situation that we're in. There's just no incentive to, from a financial standpoint, to move away from managing sickness instead of preventing it in the first place and curing it. Thank you very much. Oh, last shameless plug. If you're interested in wanting to know more about my campaign, if you want to know more support, just go to Tony for New York, TONY, 4ny.com. And now we'll open up the floor for questions. So thank you very much again. Yes.
Hi. My name is Dr. Molly Rutherford. I own my own direct primary care, direct addiction treatment practice in Kentucky. So I applaud you for taking this on, and I think we definitely need to do something about medical education. But one of the problems that you didn't mention is the lack of time that medical professionals, specifically physicians, have to spend with their patients. And the reason we don't have any time is because government is in the way. So how do you plan to help government get out of our way?
Well, that's a great question. So, I become Senator Martinez. I will be talking with the doctors in my district. I want to make your lives easier. I want to know how I can help you do a better job for your patients. And so let me ask you a question. How is the government getting in the way, taking time away from you in terms of...
Oh boy, that's a long question.
No.
Yeah.
I mean, okay, no. Okay, that's great. We see, that's great.
Yeah.
So
we can talk about that. I'm willing to talk to you about that.
Just like one of the top two things, just so we can briefly, if you will.
Because of how we are reimbursed by government and by third parties, including insurance companies, the amount that we are reimbursed is cut almost every year. It's based on Medicare. So that's a federal program, so I don't know that you can really help with that. But as a result, doctors have had to increase the number of patients, the volume of patients that they see. So for Medicaid, for example, in Kentucky, I used to see Medicaid patients, and the company that I worked for, the hospital system that I worked for, they would double or triple book my Medicaid patients because they knew they got paid nothing, and they also knew that often Medicaid patients didn't show up. So
it's like they're gaming the system.
It's just a mess. So Doug, don't get mad at me. But if anybody in here wants some advice on how to do direct care, just contact me. That's the solution. You got to get out. Don't bill insurance. Don't bill government.
Okay.
Another example of how they get in our way is we can bill a certain amount based on what we have documented in our note. So we spend all this time bloating our notes on ridiculous stuff. I have to put every single thing I told the patient, and it takes, so I spend 2 hours a day after I see patients catching up on my notes. Anyway.
Is there technology that could make it that easier? Because the reason why
there are
the reason
templates
why
and-
there has to be notes, if you're going to get paid, you got to be able to document it. There has to be an accountable way so that there isn't abuse.
It's a whole long discussion.
Yeah.
So I have other 2 comments and a question. I'll be quick. Okay. All right. Just medical education. Be careful because I work. So I'm a physician at Thomas Jefferson University in Philadelphia. I was just made in charge of 1 day of education for medical students for nutrition and obesity, and I have all these faculty members, and not one of them is like-minded, and so be careful what they're going to teach to the patients.
Sorry, excuse me, please, there's a huge line here.
Okay, all right. My real question, getting insurance. So a big lobby for the U.S. dietary guidelines is all the food companies and the big business. What about getting the insurers and the payers that are going to actually save money by better guidelines on board?
Well, the answer to that is I'm still waiting on, and this is something to talk about, for the life insurance industry, because if people are healthier and people live longer and they have life insurance policies, they're going to be paying premiums longer. And when there's a conversation in that sector, but I think there will be a moment where they're going to wake up and be the foil to this, because this is part of the problem. All right,
Sorry, just give me a second. I mean, this is
It's a huge line.
this is crazy, and it's but it's great. I didn't realize it would invoke such emotion. I'm really sorry, and I would love you to come to the back and ask
please
any other
do.
questions that you have if we have time. But we really need to give everybody a chance. It's amazing that so many people have comments and questions.
All right. As an activist you mentioned that there's a open period for submitting feedback on the dietary guidelines. Does LowCarbUSA, are you guys promoting a link to help encourage everyone? And I'm talking every keto group. I'm talking everyone should know this, because it's also based on, from my experience, the uniqueness of the emails and stuff that are sent in. So if they get 10,000 form letters, they count that as like 2. If they get 500 unique emails, they count that closer to 500. So when you get individuals sending in comments via the web and stuff and via email, so my question is are you guys communicating this to the rest of the keto group to get those comments in?
The answer is yes, and also for the benefit of the attendees here, if you want to comment on it, literally just Google LCAN, LCAN, Low Carb Action Network. All the information's there. There's also the Nutrition Coalition. All the links are there. And absolutely, it is important for people to give their story in their own words. We're not promoting form letters, but what's most compelling for the committee is people's stories. And again, speaking from a factually oriented experience and perspective. So this, dear committee member, this was me, this was my experience, I did this. Why aren't you taking this into account? This is my suggestion. That's the kind of communication that needs to be given from your own experience. And it's a great exercise as well to practice communicating your experience, that you're going to be telling it to all kinds of people, because most people that I know that go through this and they have a recovery and all of that, they're always talking about, well, I did this and I did that and I had this, and so it's an important exercise to put it down in writing as well. Yes.
I've been contacted by a Florida representative in the Jacksonville area to discuss ketogenic nutrition to address the more than $25 billion that my state spends just to manage diabetes. From a legislative perspective, what would you recommend a key point, 1 to 3 points to address with this representative?
Well, first, I'd like you to email me so I can help you
Okay.
in a more in-depth way. So I can send you some information. But I think the points that any elected official, what we would want to know is, number one, how can we bring down the cost? And what are the steps that we would need to take to implement the policy? And so, as I pointed out in this, there's a lot of pieces to this puzzle. There's a finance side, there's an education side, there's a product side to all of this. Then there was regulation weaved all into each one of these things. So it's about rebuilding, taking these pieces apart and reconstructing it in a way that makes sense so that you can get a handle on the problem. And then I would also say to you, bring your best case studies, not just because that's what makes the difference. So you have my email. Yes. Yeah, it's very easy. Tony, Tony at Tony for New York, TONY4NY.com. Okay.
Hi, I have a personal question for
Sure.
you. You received a stent for your circumflex artery. I assume you were having chest pain.
Yes.
I understand your diabetes has essentially left the scene, but what is the status of your coronary arteries at this time?
Fine. I see my cardiologist once a year. I lift weights. I have no angina or anything. I still have an unopened bottle of nitroglycerin that I was given on discharge from Montefiore Hospital now 6 years ago. I have it as a memento. So
that was
my
6
blood
years
pressure,
ago.
my blood pressure is normal. My heart rate has gone down. So my resting heart rate has gone down. So all the markers are good.
What's the status of your lipid panel?
The last set that I had, my trigs were like 67, HDL was still kind of low, around 45. My cholesterol was like 200, 220. But again, I ascribe to the Dave Feldman energy hypothesis of cholesterol, not the pathological hypothesis of cholesterol. In fact, something else that I say to people, go get a CAC scan. Find out if, where, and how much your arteries are blocked by getting that test. That test costs $100. In my district, I have some of the best facilities in New York, right in my district in Rockland County and Westchester. It costs $100, but it's not covered by insurance. But it's definitive. You'll know if, where, how much your arteries are blocked, and then it's no longer a mystery. And if you got a zero scan, why is even and a high cholesterol, why is the doctor even considering putting you on a statin? So, Dr. Iflin.
Hey, Tony. So, from my background in political science and business, you are going up against the processed food industry. Are you worried about that?
Listen, I have said this, when I had my heart attack and I recovered and I survived, I gave thanks to God that I got another chance to live, and that for whatever time I have, it will be spent in service. I'm grateful for the things that I've been given so far, like to see my son graduate from law school, get sworn into the bar, So, I'm not here to be a career politician. I'm here to get things done and then hopefully be able to retire and relax. But I'm not here to go to spend, 20, 30 years in Albany, Washington, or whatever. I want to go make some things happen, make my contribution, and actually inspire other people. If I can inspire other people, I'll probably be the first keto carnivore legislator out there. But I shouldn't be alone. There should be more of you. You should think about it. It is daunting to put yourself out as a candidate. I've spent my life as an attorney advising political candidates and doing all kinds of working in campaigns. But when you're in the front lines, it's pretty daunting because you're up against all kinds of things and all kinds of issues get thrown out of your way. And at the end of the day, like I said, I just want to be able to serve, contribute, make my contribution. As I said to you yesterday, I'm not for banning the processed food industry, but I want the people to understand, to be literate about processed foods so they can make better informed, more intelligent decisions about whether or not to use them or when to use them. But we're not. I'm not working to become somebody's nanny. I'm working to create a community and a state of more critical thinkers.
So what I'm going to say is that the processed food industry is going to get you on their radar, and they're going to fund the heck out of your opponents. So I'm calling on this community to fund you.
Oh, well,
Yep.
Thank you. Well, I appreciate that. And about that funding, I'm the candidate who's looking to do two things. I want to have the most contributors. And the good news is, even if you're not in New York in my district, as long as you're a U.S. citizen and you can contribute to me. And I'm just looking for contributions at the level of $20 to $25. I want to be have the highest number of contributors at that average contribution. That will send a powerful message to all the political party people and to the world that there is a constituency that supports this, and it represents everyday average working people. I represent the doctor, the farmer, the teacher, mom, dad, kids, policemen, firemen. Those are the people that I'm interested in representing. I'm not interested in representing big corporations. So.
All right, well, thank you for your talk. It's so inspiring, especially
Thank
as
you.
a non-medical, I'm a professional, but not in the medical field. So in terms of, so I'm not a medical professional. Is there certification that I should look into, right, to make my opinion or what I'm presenting locally to the local government more acceptable, right, or respected, or however you want to call it?
Well, first of all, if you're as a patient, no public official should demean or belittle your experience, number one. But second, if you're interested in getting into a health profession, there are different levels. So like in New York, we have diabetes educator, nurse practitioner. There's different levels. You would have to look up in your respective state and see what's available in the licensed professions to do that, and go for it.
All right, thank you. And is there a format for collecting all the data? So if I start a group in my local area, I start researching, and there are 100 people who have had a success story, is there a website or technology where all of that information can be gathered so that I can represent, here's 100 stories, here's 1,000 stories, all documented?
Create a meetup group, meetup.com. Create a meetup group, put it out there in your community, use your taglines. This is about using social media.
Okay.
So put it out there. If you want to follow me on Twitter, because I'll be talking, I'm always talking about this. It is NYTONY and the number 4, New York Tony 4 at New York Tony 4 on Twitter. And then I'm on Facebook. I have a Facebook page, Tony Martinez for New York State Senate. So just follow. You can follow me there. And
We'll use you as a case study.
use social media, and create a meetup group, and then keep talking about it. Contact the local newspaper. I've set up a community or a group that to support patients. It's just about using social media and engaging the traditional sources.
Yeah, and you know, and like if you get a list of those, like make a spreadsheet or whatever, post it on his site. Like comment on everywhere where you see people talking about this,
Right.
and post your thing. Hey, I've got this information, and then that's the way that you get it out there. Just use the social media as much as you can.
Wonderful.
Yeah,
Thank
and,
you.
and in fact, use technology. If you want, for example, if you create a group and you want me to speak, even if I couldn't fly to come in person, that's why now we have Zoom and Skype and all these other things to use technology to kind of bridge the distance. So we can do that.
Well, I think this is why you're getting this response, because for those of us who are not medical professionals, but we want to have an impact and we have experienced it and we have family members that have experienced it, how do we contribute? We're not a cardiologist, we're not a dietitian.
Yep.
What do we do? So thank you.
Just one other thing, as Tony was saying, if you go to the LCAN website and stuff like that, you can find links to how to submit your comments to the dietary guidelines, and anybody can do it. And that's what the LCAN, there's 7 or 8 of us on that committee, but like we're just helping coordinate the thing. The whole thing is to try and encourage as many people as possible to actually comment. And you don't have to be a doctor or a medical practitioner or anything. Anybody can comment. So go to that website and find the link to the dietary guidelines thing and submit an email to them and send your comments.
And post that link on your social media.
Right.
Give it to all
Yeah.
your
Yeah.
friends.
Encourage your followers and the people that you know to do the same thing.
I really want to echo that point and really encourage. In my experience, I found Twitter is very constructive for 2 reasons. You have a global audience, and whatever you are communicating, you have to get it down brief and to the point. And people use Twitter for 2 things: for information or to be entertained. And as in terms of information, it's powerful. You've learned, you can connect with lots of people. So, I recommend for this space use Twitter as well, and Facebook too, but Twitter is powerful. Yes, sir. Yes, doctor.
First of all, thank you for your advocacy. Medical students, residents, physicians, all prescribers are taught how to prescribe. They're not taught how to de-prescribe. Brian will be teaching us how to de-prescribe soon. There are new guidelines written by the Loan Institute in Boston, guidelines about de-prescribing. Would you include these kinds of guidelines?
Absolutely.
In the
I
medical
mean,
education?
it needs to be a collaborative effort. I mean, the first step is to get everybody on board with the idea that, maybe, if we're going to get a handle on our healthcare costs, we're going to need to take a look at how we're treating some of these diseases and conditions that we know can be dramatically improved through food and nutrition. And then how to safely help the patient as they respond, then those of patients that respond favorably, to guided through their doctor come off these medications. Kind of like, it can be as easy as like it was in my case after I had a normal A1C. My doctor just said, "Hey, Tony, you don't need to be on Janamet anymore. You're off. Stay on metformin just a little bit while. Let's see how you keep doing." And then, "Hey, Tony, you don't need this. You can come off all of this." Hallelujah.
All right, and a comment for you. If you make only one change at med school in your career, I would want it to be that doctors are required to wear a CGM for like an entire semester.
You see, the CGM is the game changer, and there will be a moment, and I think if we put pressure and educate on this, I think that's something that's going to actually cross the entire, the United States as a whole population. The problem is there are only a handful of CGM makers, and that's bad because there's a very good book I would recommend everybody to read, and it's called The Myth of Capitalism, Monopolies and the Death of Competition by Jonathan Tepper. And for me, that is a book that I use as guidance for economic policy. And one of the things that Tepper writes, and his co-author, anytime there's monopolistic power or oligopolistic power, anytime you have less than 5 competitors in a particular industry, you will find that prices go up, innovation goes down, and political power begins to concentrate to protect those economic interests instead of keeping a level playing field to allow fair competition. When there is fair...
Agreed. I don't want you to go too long. There's other questions, but
Okay, we have time.
one last
Yeah.
one last comment on. I didn't give you the why. The why to do it is because these are the people who are the influencers and they have no idea what affects their own blood sugar,
Yeah.
how stress affects it, how everything can affect it. And that is the game changer, is because they're going to want it, once they see it inside them and how it's affected, that's going to give them the curiosity to prescribe it more. And by the way, when it costs too much for their patients, that's what's going to drive the competition to come up with other ways to get it. And some of it's showing up already. So the CES just demonstrated, I think, one where they don't even need to insert
Yeah.
anything. So
Well, we went, so just to finish, I totally agree, finish my point. When you have this oligopolistic power, you know, we need more competitors. So we need more people making, more companies making CGMs. And this kind of competition is actually going to level the playing field, force prices to come down, and make them available to a greater number of the people, which is a good thing. And it will happen. Yes, Dr. Fack.
I'm going to do my question first. Did they teach you this in law school?
Well, I appreciate it.
Yeah. I'm going to ask two. I'm going to break the rules. How did you finish early? You're a politician and attorney, and you finished early on your timing. That was pretty amazing, too.
Okay.
So, but my comment is along your lines of what you're saying. I have two patients who are diabetes educators, and they come in and they both said this keto stuff is crazy. And I said, let's put you on a CGM. It costs you $100. Do it for a month, 2 weeks on your diet, 2 weeks on low carb. See what happens. Both of them called me and said, now what do I do? Right? Because they see that. It's pretty awesome.
You know, perhaps what we can add to the medical school curriculum is to have the medical students wear a CGM so they can see it. Yeah, right there, right in medical school. Yes.
Huge welcome packages. My friend's daughter just went, and I know all the rest, and they got lots of crap in there, so they might as well throw the CGM in too.
Yeah.
Because they have no idea.
Right. And there's nothing like experience to drive a point home.
I'm a cardiologist, and I've been, this low carb is kind of new to me over the last year. I've been indoctrinated for the last 30 years about, eating fat is absolutely evil. And so when I talk with patients about, eating, more fat, I try to push the healthy fat, but obviously, you'd commented that you're carnivore. When I bring that up in the back of my mind, I'm always thinking, am I committing malpractice? And so I'll be honest, as a cardiologist, I'm very concerned. I mean, if I advised a person, it might not hurt to eat some more meat. There could easily, and he goes and has a heart attack 6 months later, I could easily be tagged for, malpractice. I mean, could you as a lawyer maybe speak to that? I mean, what is my risk of that, I guess?
Okay, so a couple of things. In my particular case, I would call myself kind of like a 90-10 keto carnivore, which means the main focus of my diet is meat. It is meat, some type of animal product. And once in a while, some green vegetables. And I happen to enjoy red wine. So that's pretty much it. In terms of medical malpractice, you have to look at medical malpractice is a state-by-state legal process. You have to look at how it's considered. In New York, there would have to be, in New York, we have a law, the medical malpractice law is based on where the doctor departed from the standard of care, and that departure from the standard of care proximately caused whatever the injury was to the patient. I think that there's going to need to be maybe some reforms or some protections so that doctors can be comfortable. I mean, we have the same issue with the pediatric endocrinologists who would rather have the children, type 1 children, be on the blood glucose roller coaster than risk a hypo, which are, can be fatal for the kids. So there needs to be some tweaking in that. And that's something that would have to be evaluated on a state-by-state basis. But I appreciate that, and I get there. That's something I will look at because I don't want to make doctors wrong for trying to help their patients in terms with their diet or understanding. So.
And that's even more important, though, is this is what we've been doing with the clinical guidelines that we published, and trying to establish a standard of care around that. If you heard Adele talking, she was saying that when she was on that malpractice case, that doctor literally removed the wrong part. But at the end of the day, he was actually acquitted because it was other doctors that did similar things, and there's only a few of them. They agreed that was quite likely they would have ended up doing the same thing themselves. And so it's that consensus that we need to establish. That's why we need to get those guidelines out to as many people as possible and see there's more people that actually agree with what that says, the more you guys are protected if you end up in a situation like that. That standard of care is critical. And I'm asking again, everybody, do whatever you can to get that proliferated out to all your people, all your followers, all your doctors, and that's the way we do it, is to get more and more people. We've got, I don't know, a couple of hundred people that have submitted their support to the thing so far. I'm hoping in 6 months it's thousands.
I will hold, if it's in my power, I will hold public hearings on the guidelines on low carb. It needs to be fleshed out in public. It needs to be discussed, debated. And as another final thing for you, just so you know, as a doctor in terms of malpractice, in the state of New York, we have what's called, this is in the litigation, the express assumption of risk doctrine, where a patient can expressly assume the risk, and that would be a defense. But I don't anticipate, I haven't seen litigation about related to low carb or carnivore or any of that. Yeah, more time, more relationship, more connection, absolutely.
Hi, Tony. Chris Palmer, thanks so much for your presentation.
Thanks.
You bring an expertise to this movement that I think we really need. I've been saying for a couple of years that this really needs to be more of a political movement. It's really not about science per se. It's about changing people's minds, and that requires political thinking. And one of the things that I'm painfully aware of is that the low carb and keto communities are often feuding with each other, as we heard about, and we all know. And so it's almost like we have all of these third-party candidates who are just hurling, stuff at each other. And it's the rest of the world looks at us as a keto community and thinks they're a disorganized group of people that clearly aren't credible, that can't get their stories straight, that don't know the difference between correlations and causation and everything else. And so I'm much more mindful about working with existing organizations that are clearly making political ground and inserting ourselves into those effective organizations. So one clear example is a movement called Food is Medicine. And it's being done as a state. Massachusetts has it. Harvard Law School is the primary instigator of it. And they are trying to get medically provided meals for patients who are elderly and poor as part of their medical treatment. So I'm curious as to your thoughts. Which organizations can we insert ourselves into instead of trying to do this alone as the keto low carb community, which other organizations can we insert ourselves into to try to move this field forward?
Very, very good question, Chris. So there are a number of organizations that actually have spaces because for potentially keto, low carb, just simply because of their constituency in general. So for those of us over 55, we have AARP, we could start talking about that because this affects the quality of life for those who are over 55. I can think, and this is kind of more challenging, but getting involved with your local, if you want to, with the mainstream organizations and starting to create some arguments for change, like with the American Diabetes Association. There are a number of organizations that you can just look at, you have to start at the state level, local level. And the technology is out there, to Google it. And finally, most importantly also, is to continue to go to conferences like this, because it's like, and again, my thanks to Doug, who actually he always gives a platform at these conferences to talk about the politics and the policy, because it's important to keep, we do have to make our arguments with science, not just with our experiences as well. So, those are some of the organizations. I'm thinking now in my head, I'll have to think about that some more, about where we could be inserting ourselves. And that's maybe worth a topic for, the next conference. So, thank you.
Okay, just quickly, break time. I'm not sure if anybody wants to leave this conversation, but if you do, please do it quietly. Don't talk outside the door. And back at 9:30 for Chris's talk. But Tony, let's get these other questions done if there are any others.
I just one thing I'll do is I'll get the New York State Legislature, the legislators, the members of the Senate and the Assembly to wear CGMs. I know some of them who will be in shock.
And then send them to Tro.
Just a quick question.
Sure.
In case anybody in here is friends with Jeff Bezos, can you ever imagine a health insurance model where they would base the pricing on your insulin levels, since it seems like elevated insulin leads to so many other chronic conditions?
I think that's an interesting, I haven't heard that put yet, but that's very interesting to think about. Certainly the insurance companies would look at that, but that's a marker that we are not taking into account, but I think that's going to change. I think we're going to be starting to look at people's insulin levels as a clear, important marker to determine and keep an eye on throughout, because it's all related to all of this chronic disease, and it's the elephant in the room.